following the Malice Day festivities. So we want to talk a little bit about the match and a little bit about the students who matched from Mount Sinai, the people who matched into the program, our pre-residency fellowship, and then we'll move on to introduce our Malice lecturer, Lola, today. So it was a banner year for the match, really was a banner year. 5 Mount Sinai students matched, and you could see the massive success of our students. This must be the best year that we have had. Peter, do you have any comments on the success?
I mean, I think this was a concerted effort on the part of the students first and foremost, but also the faculty and pushing for each of them and their top choices. And they had a really great match. So congrats to all of them. Yeah,
this is really pretty impressive. And you'll be carrying on the tradition of neurosurgery excellence. I look forward to following each one of your careers, and I hope you'll keep in touch with me personally and with your mentors here at Mount Sinai. So congratulations, Aislinn, Michael, Will, Ted, and Adam. It's not just the medical students who are doing well. Our PRF program has grown over the past 6 years, and we have had enormous success in providing clinical experience for people who have been trained elsewhere and who would not normally get that clinical exposure. The idea that I had about 7 years ago was that there would be we saw such talent in the pool of applicants who originating outside this country, but there was this missing link of the clinical experience in a U.S. North American health system that we could provide, and that we had a need to provide given the size of the program. And so we created this that we call the PRF program, the pre-residency fellowship, with a specific goal of giving clinical experience to talented people and then providing a launching pad for them to match into a U.S. program. This has turned out even better than we thought. Ted has been running this program recently, and I really think you've been doing a good job. Ted, do you want to make any comments? And I have another slide for you as well.
Thank you, Dr. Bettison. Yeah, just wanted to stress how initially this idea back in 2015, as you said, you really saw this need of people not being able to make their way through because of perceived red flags. And we think this program has been so successful being able to erase that potential red flag before medical school, and at the same time just increase the diversity of neurosurgery in the United States and neurosurgery worldwide. Yeah, we can go on to the next slide. And I want to personally apologize to Santiago. Santiago, your photo is pending, but it will be there. He's one of our applicants. You can see the number of places these folks are from, really covering every corner of the globe. They have been able to match successfully UVA, Loyola, UCLA, Mount Sinai. The rate coming out of this program, we don't quite know if it's sustainable, but right now it's better than just the rate of applying for neurosurgery if you go to a US medical school. And the stress, again, of us being able to bring in applicants that really come with a unique story and come from everywhere around the globe. To us now, the diversity increase through this program is significant. So again, I want to thank everyone who helps train these folks and get them out there and spread the word. Thank you, Dr. Bettison.
Thank you. And of course, we want to congratulate Nick, who matched this year at Duke. That's a spectacular accomplishment, really fantastic. They are thrilled and we are thrilled. So this is success for everyone. So with that, let's turn to the new people who are going to be joining our neurosurgery family. And I'll turn this one over to Raj.
Thank you, Josh. So We are extremely happy, and it's even more than happiness. It's really one of those sentiments too, of thankfulness as well, to really match two outstanding women. Chi and Emily both we know very well. Chi had, thankfully, I know Lola is here, so Chi had been directed to us by Lola from Vanderbilt. She did an amazing job with us as a sub-I, truly outstanding. She did her undergraduate at Emory, and then obviously her medical school at Vanderbilt. She had done time at Oxford as well. Stellar academics, and really impressed everyone with not only her work ethic and intelligence, but compassion and ability to step up, which really impressed all of us. So we're very fortunate to have her. I'll have her say a word in a second. And Emily, we know very well also. She's a student here, of course, at Mount Sinai. She had spent time not only during her earlier years, but then did an academic year and really spent time with Dr. Mako as well. In addition to working with Dr. Germano and Dr. Creedy initially, she did her undergrad at Williams. She did post-bac work at Columbia, and of course her med school here. So thank you both for joining us this morning, and thank you both for being and welcome part of our environment, culture, and not only that, but really to the residency altogether. So thank you both. So maybe if you can say a few words, I can start. Emily, you can start first.
Thank you so much. I mean, I obviously overjoyed and thrilled to be joining you all. And I just over the years have just become more and more excited about my career, and it's really just a dream come true. So I really, thank you so much to the leadership of the department, wonderful mentors, the residents I've just so enjoyed working with, the staff in and out of the ORs. I just really could not be happier. So thank you so much.
Welcome.
Thank you.
You can go ahead.
Good morning, everyone. Thank you so much for the kind introduction. I'm incredibly excited, and it's an amazing privilege to join a team at Mount Sinai. So thank you so much for having me, and I greatly look forward to starting intern year very soon.
Good. Remember, both of you, we talked about your day off after the match, so we'll get you started with your next projects in a couple of days. All right, that's wonderful. Well, it's this time of year again to introduce the Malice Lecture. This is the 12th year of this lectureship, named after the former chair, Leonard I. Malice, who was himself an alumnus in the class of 1950. Remember, this is our 75th year as a residency program, with a program, the department that began in 1914, making it one of the older departments of neurosurgery in the world. This was established by Ruth Malice to foster the memory of her husband. Dr. Malice was quite an interesting figure, peripatetic, with interests in engineering and high-speed sport boating, radiology, and of course, neurosurgery. We all know him, everyone, the world over knows him for the Malice bipolar, which was just something that he threw together in his garage to facilitate coagulation. And, as so many wonderful inventions are, aim to solve a problem that you are facing. This was one of those that he almost didn't think twice about, he told me. Threw it together, it was so obvious, and it became the standard worldwide. Can you imagine operating in the brain before the bipolar coagulator? It's hard, it's really hard to imagine. We would rely much more on our intrinsic and extrinsic clotting factors in those days. But the bipolar serves as a fundamental instrument. He was also someone who brought microscopy to the United States and to New York, having been the first person to do this here. He stayed on as chair, and when I first started as a young attending, he was still present. I was invited to join by Cal Post, and I learned a lot about how it could be done by watching Dr. Post come up as a fresh chair into a place with such a giant as Leonard Malice, and watch the two of them work together for the 3 or 4 years that Dr. Malice stayed on as an active operating neurosurgeon with the new chair, sitting side by side. Those were truly giants. And, you know, in those days, I was way, 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 way back, way, way down in the back, and watching them interact and watching Dr. Post grow and Dr. Malice step aside was something that has, you know, stayed with me this entire time. So it's really nice to have a lectureship. Here's the committee that chose Dr. Chambliss today, and she is an outstanding choice. And she follows on some pretty impressive people. Lola, I'm sure you'll recognize every one of these names, and you will feel probably just about as humbled as you can, knowing that these are the people you're following. So with that, I'll turn it over to Raj, who led the search committee.
Thank you, Josh. It's a pleasure to introduce Dr. Lola Chambliss. I've been fortunate to know Lola over many years, not only from our involvement both in the world of skull base, but through residency work and through the Senior Society as well. Lola is the Associate Professor of Neurosurgery, Radiation Oncology, and Director of the Residency Program at Vanderbilt. She did her undergrad at Stanford, her medical school at Vanderbilt, where she also did her residency. She did not only an infolded fellowship, but also did a formal skull-based fellowship with Charlie Teo in Australia as well. Lola's has a remarkable series of accomplishments, as you can see from this slide, not only in her distinguished research, clinical trial work, of course, all the residency work that she does, but she's really emerged as a national leader. And I think that's where many of you probably know her. She's been involved with the CNS for many years and now is part of the executive committee. She will be this year's chair of the scientific program committee that's going to be in San Francisco. She's an elected director at large for the North American Skull Base Society, which is prestigious in itself as it recognizes not only accomplishment, but intrinsic leadership. And then within the Senior Society itself, she's also been actively involved in probably what has been really tumultuous last few years with COVID and trying to develop a platform and leadership and how best to conduct the interviews and advocate for medical students. And for that, she's been on the medical student committee and will serve as its director and chair. On top of everything else, she's a remarkable mom. And I follow, Lola, I follow you on Instagram, all the pictures and time you spend with your daughters. It's truly remarkable and very impressive and a real role model. So thank you very much, Lola, for coming and spending time with us this morning and for being our next Malice Lecturer. Welcome.
Thank you. Thank you so much for that incredible introduction. I'm going to pull up my slides here. Wow, this is such an incredible honor. Thank you to the entire department. It's also a real delight to get to enjoy a little bit of the news about your graduates who are really making a name for your program out nationally. There's a lot of buzz about the number of medical students that you guys are putting into neurosurgery, and I think that really reflects the tremendous mentorship and the strength and health of your department. So congratulations on that, and in particular, congratulations on recruiting Chi to your department, who I know well and is truly a spectacular student, as you guys know. You've really scored an incredible victory there. So I am going to be interested in following her career for years to come, and I'm glad that she's strengthening this Vanderbilt and Sinai relationship that we've developed over the last few years. It's an incredible honor to be asked to give this lecture, so thank you. In preparing for this today, I did some research into Dr. Malice and got a sense of his career and was really just blown away by his remarkable legacy, and to be offered the opportunity to speak and a lectureship under his name is really just remarkable. As I thought through what I wanted to discuss, I thought a bit about his legacy, and I really felt like there were two main areas that I wanted to focus on today. And one of them is really, an aspect of innovation that I think is probably very different than the type of innovation that he performed, and yet analogous and related to where we sit in 2022. And so most of my talk today is going to be really focused on the innovative and disruptive forces of artificial intelligence in neurosurgical oncology, and how this is this emerging field of data science and AI is really going to revolutionize what we do, just as some of the technical innovations that Dr. Malice made revolutionized operative techniques. And then I'm also going to share along the way some lessons that I learned both about engaging in a new scientific space, but also about mentorship and the power of bidirectional mentorship and how that can help to grow and enhance your career. These are my disclosures. Raj mentioned most of these, so I just have some fiduciary responsibilities as a board member for these societies, and I will be discussing my work within the CNS specifically at the end of my talk. So I'm going to start with that mentorship piece a little bit. This is a student who's now a resident, Whitney Milstein, who's now a PGY4 at the University of Michigan. And when I returned from my fellowship and came on faculty in 2013, I built out the lab that I had started building as a resident, looking at brain tumor outcomes from a fairly traditional outcomes analysis methodology. And I had a number of students interested in participating, and Whitney was one of those. And she wanted to spend a year doing research with me in my lab, which was fantastic. And we got her going on a project that we ultimately abandoned because it was way more boring than what she came up with. And I remember one day early on in that year, she came to kind of our bi-weekly meeting with her computer, and she said, Dr. Chambliss, I've been thinking about this, and I really think we should consider using machine learning techniques to evaluate these outcomes. And I said, Whitney, what is machine learning? And she said, well, I thought you might say that. So here's kind of how I've been thinking about it. And she spent the next 40 minutes or so teaching me about this entire field of computer science and data analytics that I really knew nothing. And by the end of that meeting, I pretty much said, let's throw your other project out the window. And oh, by the way, I might be throwing most of my other projects out the window. What you've had to share with me is so compelling and interesting that I think it really might change the whole direction of my academic focus. And in fact, it has. So I owe a great deal of, my success to really the student who just gave me such an incredible gift by being willing to share her exciting ideas. And the lessons that I've learned from that are, first of all, you have to be approachable as a mentor. You have to be somebody who your mentees feel safe coming to your office and describing something completely different and new than what they were supposed to be working on. And by all means, encourage creativity amongst your mentees. We surround ourselves with people who are smarter than us for a reason. Encourage that creativity and embrace it when they come up with new and interesting ideas. And then, I think you could actually build an entire academic career really just by recognizing and promoting good ideas when you see them. So if you learned nothing else from my talk today, hopefully that's a takeaway that is kind of reassuring to the junior faculty, perhaps. So what is AI? You guys are very experienced in this space. I'm not going to spend a lot of time on definitions here, but what I'm going to talk about today are sort of things that fall under the big umbrella of artificial intelligence that it will impact neurosurgical care, and in particular, neurosurgical tumor care. And so this is going to include things like robotics, machine learning, and deep learning. Why is AI such a unique and powerful tool? It's really involves three different aspects of this type of methodology. The use of data streams beyond text, vast computational power that is allowed through this type of analytics, and the ability to create algorithms and analytic processes that both learn and adapt to incoming data constantly. And ultimately, AI has now been, I think, demonstrated in our field in the last few years to be an incredibly disruptive force, and disruptive for good. I would propose that AI is to neurosurgery as disruptive and as impactful as in the development of endoscopy was to skull-based surgery, and even endovascular technology was to cerebrovascular surgery, which means that those of us that are already out of training at this point have to figure out how to learn enough about this type of technology that we can integrate it into our practices. And those that are in training now have an incredible opportunity to lead in this emerging scientific space. We'll talk a little bit about how to develop those skills, actually. So as I tried to really bring this back to what I do as a brain tumor surgeon and how that's impacted by artificial intelligence and how it will be further impacted in the future, I thought about my job as a tumor surgeon and really broke it down into kind of 4 things that we do. First of all, we sit in the clinic or the emergency room, the consult room, interpreting a case and assembling a differential diagnosis. And that's heavily reliant on imaging, but also reliant on some aspects of the clinical presentation or patient in front of us, neurologic exam. We construct a treatment plan. Oftentimes that's an operative plan. Sometimes it's not. Those are equally important plans. We perform an operation. That's the fun part, right? And it confirms a diagnosis. That's a critical part of what we do. And also advances the therapeutic goals. That may be things as simple as decompression as mass effect, and maybe things as complex as definitive therapy. And then we're not done and the operation's over. The last phase of our treatment of these patients is to efficiently navigate that post-operative period that's so high risk, hand these patients off to an oncologist, radiation oncologist if that's indicated, or be their long-term surveillance partner and make the decisions about how each of those steps should be undertaken. So as I broke this down, I thought, let's talk first about kind of this evaluation and planning phase, and how is this going to be affected in the next decade by the advances we've made in artificial intelligence over the last few years. So I hate to say it, but neurosurgery is perhaps a little bit behind in utilizing AI in our clinical spaces. I think there are other fields, particularly in imaging, that can show us really what can be done and inspire us to do more. I'm particularly interested in this field of mammography. And for those that know very much about breast cancer, this is a field that has really struggled because mammography has been historically very difficult to interpret, and the high false positive, high false negative rate, and even expert radiologists and mammographers have difficulty making truly accurate, sensitive diagnoses. And so this is an area that's ripe for disruption. This is a relatively recent study that came out that's now been validated externally, and there's efforts being made to commercialize this tool that actually allows and it creates a deep learning algorithm that allows the diagnosis of pre-malignant lesions up to 5 years before they develop. And you can imagine how on screening, this type of information is incredibly important. I am not a mammographer, nor is probably anyone on this call today. But if you look at these 2 images, and you look at the image on the left, how on earth would you know that particular spot is worrisome, whereas all these other spots are? Realistically, that mammogram is read as normal by an expert radiologist. And yet 5 years later, that's developed into an abnormality. And that was detectable through deep learning technologies, which would allow women to have the opportunity to make decisions about treatment well in advance and without the specter of cancer looming directly on them. So how would we take that kind of technology to the neurosurgical space? I think part of what we want to do is we want to see how deep learning can replace some of the biopsies that we do. As any tumor surgeon on the Zoom today will know, biopsies are not particularly rewarding operations. I think most of us don't really like doing them. And in part, that's because we know we're putting a patient at some degree of risk and we're not really advancing their therapy. We're giving them some answers, which are hopefully helpful, but we're often struggling with the fact that we may have to return based on what that pathology is, or we may suffer complications simply in the effort to get a diagnosis. So where do I think this is coming in the near term, and what are we specifically working on? It's really 2 areas. One of these is in patients who present with a scan such as this. And you see this confluent, heterogeneous, enhancing lesion with a lot of edema and T2 abnormality, an elderly patient. And most on the call will recognize this as a case where you say, is it lymphoma? Is it GBM? Is it something else? But really, is it one of those 2 things? And those are diseases that are treated very differently. This is a patient who maybe gets referred for a couple of LPs that are negative, and this draws out over several weeks because you're trying to avoid putting a needle in their head, or you put a needle in their head and it comes back as a GBM. And what do you do with that? Do you bring them back or not? This is an area that I think is ripe for a deep learning style radiographic diagnosis that would allow patients to get on with treatment quickly and avoid some of this inefficient and potentially risky interventions that come behind that. The other case that I'm particularly interested in is in the case of radiation necrosis versus tumor progression. And here we have now patients who have been treated for their systemic malignancies much more effectively than they were in the past. We have patients with intracranial metastases that are now 5, 7, 10 years out from their radiosurgery. And so we have this burgeoning population of people who have ongoing imaging changes and findings that may be treatment effect or maybe tumor progression. You can see in this example of a patient of mine here, you have multiple lesions that have been previously treated, and now you have a lesion that's growing a bit with increasing edema. Is it radiation necrosis? If so, you sure would like to avoid operating on that patient, try to ride that out, perhaps try some medical interventions for them. Is it tumor progression? If so, you sure would like to get in there as soon as possible and remove that tumor and potentially retreat them. As it is now, I think there's no good imaging modality that allows us to differentiate between these things. And I often follow these patients for months, with repeated scans, riding this out, how much steroids can they tolerate, making decisions about when we'll eventually go back in. And it's a very challenging issue of really what's in part cancer survivorship. And I think it's going to be something that we see, in an incredibly large population of patients in the coming years, given some of the advances in targeted therapy for systemic disease. And so this is a space where I think, true imaging diagnoses is going to be critical. There are some other areas in addition where we're not so much interested in making a diagnosis as we are about better predicting tumor behavior. This is a patient who I saw recently, took care of recently. This is a scan from 2017, and I didn't order the scan, and you can see it's not a dedicated scan. This was ordered for some other reason, but you can see that there's a small tuberculum lesion here. And this was actually not told to the patient. It was actually interpreted by the radiologist, but somehow the patient didn't get this information. And so we can follow the natural history of this tumor because the patient did not have any referral for follow-up. And so over the course of 5 years, that little tuberculum lesion turned into this thing. And this is a patient who's a healthy Ironman triathlete in her 50s who went blind in one eye and virtually blind in the other by the time she was ultimately diagnosed with this and sent into clinic. And, it's interesting, we don't look at the natural history of these tumors all that often for good reason. But when I looked at her scan and, when she presented to me recently, I thought to myself, gosh, I wouldn't really have predicted that this tumor was going to. And it's relatively uncommon to have an opportunity to look at the tumor behavior across a period of time like this. And it leads me to ask, what I really would have wanted to know in 2017 if I'd seen her was how quickly is this tumor going to grow? And will this patient begin to lose vision, and at what point? Is there a way to better predict that? Because in 2017, I probably would have looked at this tumor and said, yeah, you're going to lose vision eventually. Yeah, you're going to need surgery eventually. Should we do it now? Should we follow you in 6 months? Should we follow you with intermittent visual fields for X a number of years? And really not had a lot of good answers for this patient in this uncertain situation. This is a different type of meningioma, and it relates to a problem that we have worked on in my laboratory, which was the idea of trying to diagnose more aggressive meningiomas based on preoperative deep learning evaluation of their MRIs. These are 2 women I treated in the last few weeks. Both of them presented with seizure. They have relatively similar tumors. And if I was in the room with you guys, I would take a poll and say, which of these do you think is a grade 2 tumor? Which of these is atypical? I looked at these both in the clinic and I said, I think that one on the left looks like it might be atypical. I think the one on the right probably isn't. I thought that because of that kind of fringy border with the brain, maybe representing some degree of brain invasion, as well as the underlying edema being somewhat out of proportion to the size of that mass. But we built a deep learning algorithm a few years ago that really is able to answer that question and able to say, yes, this one on the left is grade 2 and this one on the right is grade 1. And that's nice. And I was kind of excited about that for a little while. The reality is it doesn't tell me actually what I want to know as a surgeon for these patients. Because what are we going to do with these patients? We're going to take both of these tumors out. There's really not any question about that. And so we take both of these tumors out. These patients both get the same operation. Patient on the left, tumor is a grade 2. Patient on the right, tumor is a grade 1. In both cases, we opt not to sacrifice the superior sagittal sinus. They have a nice result, but we know both of these patients are at risk for recurrence. And frankly, I've had plenty of patients with grade 2 tumors that have not recurred in the decade I've been in practice. And I have had plenty of patients with grade 1 tumors that have recurred and recurred early and aggressively. And so what I really want to know is not what grade are these tumors. It's interesting, but somewhat academic. I want to know, will this tumor recur and when? And where is there residual disease? Where is this potentially going to recur? Because that's what's going to guide my next decision, which is, should I recommend radiation? Should I recommend it now? And then really, will it change the course of disease? And that's a question people are asking with a larger multi-institutional clinical trial. But I think that better imaging evaluation of these tumors would help to guide that question much more efficiently, because this is a relatively rare disease, especially atypical meningiomas. And coming up with clinical trials that allow the power to actually answer that question is difficult. This type of deep learning algorithm, I think, can facilitate that. So, I think there's a lot of opportunity here, clearly. But as with anything else, there are significant limitations and pitfalls. And the thing to understand about this type of machine vision or deep learning technology is that it can be highly predictive, but it can also create, be based in flawed associations and really amplify some disparities. The most important thing to know about this work at this point is that you have got to externally validate this type of project. Some years ago, maybe 4 or 5 years ago, a lot of people were publishing in the space without external validation. Luckily, that has, I think, pretty much slowed down as we've recognized that performing this type of work in your own center without evaluating how your algorithms perform elsewhere is a major flaw. This is a project that was performed here at Mount Sinai by my friend, Dr. Orman, when he was a resident here. And it's one of my favorites to talk about in terms of explaining this issue. You guys here performed this evaluation to try to understand how to diagnose pneumonia on chest x-rays, built an algorithm that performed extremely well in the Sinai population. But before publishing that, went out and validated that at the NIH in a very different population that was predominantly outpatients. And the algorithm performed terribly in that group because ultimately what was determined was that the algorithm was essentially cheating. The model was cheating by looking for chest x-rays that were portable and saying, oh, those are much more, highly weighting that portability in terms of making that diagnosis of pneumonia. And the bottom line is models cheat. While they're extremely useful to us, there's still a human element of this that's required to go in and to build these models in such a way where we can understand what type of permutation importance that we build in so that we can evaluate how the models are making some of these predictions and correctly alter some of those components of the data that we are inserting. So how do you get around this these days? The problem with external validation is really that it's incredibly time consuming and involves a lot of issues related to HIPAA, privacy, and large quantities of data, which are difficult to transfer. So I really think the answer to this is going to be in federated learning. And this is what we're working on now at Vanderbilt in collaboration with 5 other centers. And this is what's happening with your cell phone every day with whatever platform you're using, where there's a central computer that builds a basic model, sends that out to all of the other actors in the project, allows those actors to train that model on their data, and then to return simply that model rather than data back to that central computer, who then can build an ensemble model that is more predictive across all of those spaces, which then gets returned to be tested again. This type of system requires some work to get up and running and a lot of collaboration, but ultimately this is what's going to be necessary in the long term to really create a model of radiographic interpretation that's going to work across multiple centers. So what about the fun part? Once we've made that initial diagnosis and plan, how is AI going to help us actually perform an operation? I think there's a couple of ways. As tumor surgeons, we are also, at least amateur pathologists. I think all of us have an interest in neuropathology and enjoy really getting to understand that aspect of our care. There is a fabulous paper that I've noted here out of Nature Medicine from a year and a half ago, looking at ways to do near real-time intraop brain tumor diagnoses. And this is based in a relatively inexpensive technology called stimulated Raman histology, where you essentially take an unprepared piece of tissue directly in the operating room, run it through a specific type of scanner that creates an image that's initially black and white, but essentially can modify that image so that it looks like what we would interpret as a typical H&E. And here you can see the similarities between the stimulated Raman histology, which is not actually dyed, and then the H&E that you would see from both a frozen and a paraffin embedded sample. And so this type of pathologic analysis is generally significantly better than what you see in frozen because there's so much less artifact. But where these authors really took this to the next level was then to build a machine learning, computer vision type algorithm that would actually make the diagnosis without the need of pathologic review. And so that then takes this from a place where you can say, okay, this is useful to share with the pathologist and try to get a real-time answer about what this tumor is, to a place where you can say, I don't actually have to have a pathologic expert, a neuropathologist, evaluating this to get really useful data that's going to drive my intraoperative decision-making. So where does this help us? It's all the places where we find ourselves making therapeutic decisions based on pathology information, which is often incomplete at the time of surgery. Glioma versus lymphoma, is a classic, but also things like plasmacytoma of the skull and the skull base occasionally can be difficult to make a diagnosis of on frozen. The place that I'm really interested in seeing if this technology can be helpful is in the differentiation between the two types of craniopharyngiomas. Some of you may know papillary craniopharyngiomas are more rare. They represent about 10 to 15% of these tumors, but we have now determined that the vast majority of them have a BRAF mutation that's targetable, and they actually respond extremely well to targeted medical therapy. And you can imagine if you could make a diagnosis about the type of craniopharyngioma you're dealing with in a complex case, you determine this was papillary, you might reduce the risk of that operation by lessening some of your surgical goals to decompression with a plan to treat that patient medically postoperatively. Might even retain pituitary function, for example. Might decrease your risk, stroke, CSF leak, et cetera, by reducing the size of your exposure. Chordoma and chondrocytoma are also classically difficult to determine on frozen sections, and really spinal cord tumors. And I show an example here of a patient of mine that I operated on relatively recently. And looking at this, preoperatively, I thought this is very likely a hemangioblastoma. Got into the case, sent to frozen. They said, nope, it's not a hemangioblastoma. And I said, I really think it has to be. They said, we think it's an astrocytoma. And it had a plane, I had it exposed. I really felt like it was a hemangioblastoma. And I was stuck in this position of saying, do I proceed with this operation? That would be wrong, probably, if this is an astrocytoma, or do I close all of this back up again and wait and get the final path? And I, better for worse, proceeded, took this tumor out. Patient had a good outcome. 5 days later, they said, oh, never mind, it was a hemangioblastoma. So these are the spaces that I think we could really benefit from some better objective analysis at the time of the operation. And of course, this has tremendous possibility for environments where neuropathology is not immediately on hand. What else is happening in the world of pathology? The other thing that's really interesting is the new ability of some deep learning analyses to actually determine mutational status in tissue without sequencing. So this is an example of a lung cancer where there's now a number of centers that have the ability to determine what mutations are present, what targetable mutations are present in this tissue based purely on deep learning analysis of paraffin embedded tissue without staining and without sequencing. How does this help us? This makes precision medicine potentially faster and cheaper. If you can avoid sequencing, it's much more efficient. Potentially will improve trial access and really improve our ability to perform early patient counseling. I'm sure all of us who do glioma surgery at this point are used to where the current state where we see the patients back and we say, well, it's a high-grade glioma, but we're still waiting for this, this, and this. And then that takes another week or 2 weeks or 3 weeks to come back before we're really able to tell the patient all that we know about their tumor. This type of work could potentially narrow that diagnostic corridor significantly. What about the way that we actually do the operations? This is probably the area of neurosurgery that's seen the least advance in AI up until this point, but it is certainly coming. This is not a brain tumor operation, obviously, but I throw this in here because I personally think the most exciting aspect of AI-powered robotics are going to be in neurointervention and in stroke. This type of technology exists now to do robotic thrombectomy. But what I think is really going to be interesting is to develop a system that can do an AI-guided thrombectomy without having to have an expert surgeon at the bedside. I think that has the potential to be a complete transformational game changer in the way that we manage stroke. Within the field of skull-based surgery, I love this video, which is from Bill Caldwell's lab at Utah, demonstrating a robot that they have created with their engineering colleagues that actually performs the translab drilling independent of a human operator. And it uses the CT to essentially build a plan and takes that drilling time of doing a translab, they say from 2 hours to 2.5 minutes. And my OR, that translab drilling is sometimes often in excess of 2 hours. So you can imagine how this could revolutionize the way that we do some of these complex skull-based operations. And this is a first-in-man robot that's being trialed in Europe to do the same thing. Of course, this will potentially have implications for training. How do we train people to do these complex operations if we have a robot that can do them more safely? That's a question that is as yet not answered. So last but not least, as I mentioned, the other thing that we do as surgeons is we make sure that our patients are shepherded carefully through the period after their surgery. And a lot of our job, both before and after the operation, is to try to answer their questions about prognosis. And the bottom line is we know that doctors are terrible fortune tellers. We are really bad at this. And this is a fantastic book that really gets into the weeds and the details of why that is and just how bad we are. We tell our patients they're going to do better than they actually are going to do. We tend to underestimate our complication rates. And of course, there's bias all over that system. And so, in the last minutes of my talk, I want to talk a little bit about what I took away from my fellowship in Australia that led me to think about this type of prognosticating and sort of minimally invasive approaches that have guided some aspects of what I do in my own research. When I was in Australia, I went there in particular because I was interested in learning minimally invasive approaches, both to skull base and to intrinsic tumors. And what I really took away from that experience was that minimally invasive is not just about small incisions or small craniotomies. It's about using less interventions overall, less waste, less unnecessary medications, imaging, shortening hospitalizations, using the ICU less labs, less monitoring, et cetera. And it's an incredibly powerful experience to go practice medicine in a very different environment at some point in your career to see how much of what we do may be entirely unnecessary, and then to think about whether if it's unnecessary, it may actually be harmful. And so a lot of what I've done has been to try to build out point of care models that demonstrate this aspect of what is probably overtreatment in a lot of the American neurosurgical space. And I'm going to breeze through these, but the bottom line is that what I think is most interesting at this point is the idea that we can create models that you can sit and look at in your clinic with your patient and say, how are you going to do? And so, for example, this model predicts length of stay. We've all sat there with our patients and said, yeah, you're probably going to be there 2 nights, maybe 3, might need rehab, probably not. We got to know that we're overestimating how well our patients are going to do most of the time. And effective patient counseling starts with really knowing knowing that what you tell your patients is accurate. So this is an example of a point of care model that we built a few years ago that allows you to input just a few key variables and then predicts how long your patient's going to be in the hospital. And, you know, I did use this for a patient of mine recently, who's a 70-year-old Black woman who had some hyponatremia at presentation. Otherwise, really no risk factors at all. Predicts a length of stay of 13 days. You look at that and say, that's insanity. There's no way that patient's going to be in the hospital for almost 2 weeks. But if you do this repeatedly and you learn to trust some of these models, it's actually really useful, because then you can identify targetable, mitigatable risk factors that might help. Why is this patient going to be there for 2 weeks? What does that tell us about, you know, her presentation, but also potentially some things that we can do on the front end to try to optimize where she's going to go. Because if she's going to be in the hospital for 13 days, she's not going to go home after that. So how can we identify ways to shorten that time by being thoughtful at the front end? This is a natural language model that we use to try to make this even easier for folks in the clinic. So this is a point of care model where you can essentially just plug in your clinic note and the MRI report, and it will tell you whether your patient is likely to go home after surgery or somewhere else. And it will tell you that with better accuracy than actually plugging in 52 different expert guided variables that we think are prognostically relevant. This is really simple. Here's an example of how you can do this if you want to try it out. And essentially you can determine within 30 seconds, your nurses can plug this in for you and tell you within 30 seconds, you know, is this patient likely to go home or not? Incredibly helpful information to have for a family. And in my mind, is really just useful for us as physicians to continue to adapt the way that we counsel patients. It's less helpful probably on the per patient basis and more helpful in terms of allowing me to better understand how my patients truly do, reducing some of my own biases. So where does this help us? Obviously with patient counseling, and also putting the brakes on high-risk procedures. You know, we all get into the dangerous zone sometimes of feeling like, you know, oh, this is risky, but I can probably get this patient through it. And I've done this operation a bunch of times and I really want to help them and they want to have surgery, and potentially offering things up for patients that are not actually in their best interest. And I found that this type of point of care modeling can help me sit back and say, you know, does this really make sense based on what this patient's goals of care are? The caveat to this that I often hear is people's concern that, that this may affect reimbursements. You know, if we publish and start using point of care models that say how long a patient should be in the hospital, and then they're in the hospital for a longer period of time, are we going to get paid for that additional period of time that they're in the hospital? I think that that's an important concern, but the reality is that that is going to happen whether we participate in this type of research or not. And we are far better off having some control of how this is looked at and how this is researched and how this is published than if we don't have control of that and we are dealing with payers doing this type of work on their own. So I've talked about what a brain tumor surgeon does clinically. In the last few minutes, I want to shift to the other thing that a brain tumor surgeon does, and that's really about mentoring others and advancing the field overall beyond the care of our individual patients. So I mentioned Whitney at the beginning of the talk. Whitney did the vast majority of that work that I just demonstrated several years ago, and truly changed the way, you know, the direction of my academic career, which is incredible, which is just remarkable to me. That mentorship is bidirectional. Obviously, I've helped her throughout her path, but what she gave to me was a career direction that actually helped put me into a new space in organized neurosurgery. And so, you know, that story continues. And that a year or two after Whitney and I started doing that work, Ash Sharon was the incoming president of the CNS. And he was introduced to me by a mentor of mine. And we got to know each other, liked working with each other. And he said, you know, I'm interested in thinking about what you could do for the CNS. And what are you really interested in? And I said, well, I'm interested in resident education and skull-based surgery and this, that, and the other. And he was like, yeah. A lot of people are interested in those things, right? And I said, but recently I've gotten really interested in big data science and artificial intelligence. And he said, well, that's what we need. We need someone in that space. So he said, you know, let's ultimately decided to bring me on to the CNS executive committee to run the new data science ad hoc committee. Without having had that skill set, I don't know that I ever would have wound up there. And so the story of what I have done through that opportunity is something that I'm really proud of, and I think is hopefully instructional for people who are interested in organized neurosurgery. So Ash brought me on to the executive committee at a one-year appointment to run this new ad hoc committee. which essentially means, this is a committee that we're just going to run for a couple of years because we think it might be important to engage in for a period of time. The first task was to try to come up with something to do at the annual meeting. And so ultimately I was given a space of several hours to do this symposium on big data. And I was so excited. I was like, several hours, that's a big space, I get to build this out, do whatever I want with it. And then as I got closer to the meeting, I realized that the Wednesday afternoon period is where things go to die. And so the space that I had been given was like the excess space that nobody wants. But I realized, it's still an opportunity is an opportunity. So we put together this session, which was given on Wednesday afternoon after most people have left. And I did everything I could in my power to market this. And it was really remarkable because people actually showed up. And I remember this nice tweet from Ash as he was personally standing there with his suitcase leaving the building, saying, really describing the fact that we actually had a pretty remarkable turnout to this event, and saying this is not the end of the meeting, but the beginning of a field in neurosurgery, which got me really inspired and excited. And so this was surprisingly successful, which meant that we had the opportunity through our committee to do something else. So the next year we thought about creating a practical course. People actually paid to come to, and people did pay to come to it, which was remarkable. At this point, I had sat on this committee for a year or so, and in getting to finally know other people who were working in this space, shared a lot of the problems we were all having. And we all realized we were having a lot of difficulty with review of our manuscripts, in that they were being reviewed by editorial boards that had expertise in traditional statistics, but not in advanced data science. And because I sat as the committee chair, I had the ability to reach out to the editor-in-chief and the managing editor at Neurosurgery and say, look, I really believe that CNS and our journal should be the leaders in this space, but I and my committee members are all doing work in this space that's continually rejected by our journal for reasons that I think are based more on a lack of understanding of this methodology than the scientific merit of what we're doing. And they thought about that for a while, and they said, well, how we agree, it's a problem. What if you had the opportunity to put a few people on the editorial board, which is an incredible opportunity. And so I chose Eric and John to join as associate editors specifically in this space. And I will say that completely revolutionized the way that data science work in neurosurgery gets published in the journal. And now this is clearly the home for good work in this area, and a great responsibility and opportunity to try to change the field from within my small post. We also wrote a couple of papers to get our sort of group's name out there, to make sure that people knew that we were the ones working in this area and to come to us with their ideas. And then in 2019, decided to try to engage with industry a little bit more here. And so started working with NVIDIA, who builds the GPUs, through which we do much of this type of work. Got them to donate a GPU as an award, the first ever data science award at a neurosurgery meeting. Also had them come and do this type of kind of showcase where people can stop by and check this out, which really just builds the excitement and energy from this field. That award was really interesting to me because this is the first time any such award had been offered. People could apply for it when they submitted their abstracts, just like with the Abstract Center now. And there were 200 or 300 people who applied for it. And ultimately, I thought there would be some scheme through the scientific program committee that would determine who got this award. But the scheme was like 3 days before the meeting, they said, oh, Lola, who should have the award? Well, they said, well, look through them and decide. So I looked through all the applicants for it, and I found this paper that I thought its abstract was really interesting. This is Todd Holland from Michigan, and this was that Intraop stimulated Raman histology project that I showed you a little bit earlier. So I thought this abstract was quite good, and then I looked at how it was scored, and it was scored like a 3 out of 5. And I looked at where it was being presented, and it was being presented at the little 3-minute podium talks within the poster session that are not very well attended. And so I had some hesitation. I thought, maybe this isn't like a top ranking abstract. It isn't the one that should win this award. I said, no one seems to care. So I think it's really good, and I'm going to give this one this award. We gave Todd this award, and that paper, the paper from the abstract was based on was then accepted into Nature Medicine 6 weeks later. And that was really remarkable to me as someone who wasn't in a real powerful position on the scientific program committee. I said, gosh, we're having the same problem in our meeting that we were having in the journal, which is that we're not necessarily recognized recognizing the best work in this space with our typical abstract review process. Because if this is a project being published in Nature Medicine, the project maybe should have been on the GSS stage, the big stage, certainly not buried down in the posters. And so that really got me interested in reforming some of the ways that we think about abstract review to get the very best science up on the podium. During this time, we also were able to turn the Data Science Committee into a permanent standing committee, and I was also able to hand it off, which is a great accomplishment in and of itself. But we also created this opportunity, and we're now in the third year for this, which is the CNS Scholarship in Data Science. Because one of the things that we recognized on our committee work was that we just were a really small group, and we needed more neurosurgeons who had true expertise in this. And that's not going to come from people my age. They're not going to go back to school at this point. It's going to come from our current trainees. And so this is a scholarship that supports a resident with substantial monetary support and, most importantly, substantial external mentorship to really complete some interesting projects during a research year. They can still do their in-house work. This is intended to be about 40 hours a week, so it doesn't mean that you have to be completely protected, but it gives you a great opportunity to really become a content expert and then join our committee and help guide the CNS in this space. Ultimately, I then also have become now the scientific program chair for the CNS, which is a really outstandingly exciting position. It's the job I've always wanted in organized neurosurgery. And this finally gave me the opportunity to kind of mix up the way that we do some of these abstract reviews and really rethink about how we get the best science forward. And I was able to create specific sessions to highlight the science that I'm the most interested in right now, which is an incredibly incredible opportunity. And so one of the things that I did was say, we're going to have a specific data science session. And so you'll see in San Francisco on Monday morning during one of the sunrise sessions, 90 minutes devoted to data science abstracts with a great external speaker who comes to us from Google Health and AI. And the best work in this space will hopefully be submitted and really demonstrated to a group of people who are interested in this type of methodology, rather than looking at these abstracts from a disease state basis where they're just shuffled into different section sessions. We're really saying, there's some aspects of research that are more methodology focused than they are disease focused. And I think that's a different way of looking at at the way that we run our meeting, but I'm excited about it. I'll also mention, because when you're the scientific chair, you get to get all of your fun ideas put up there for 1 year. We're also doing the same thing in medical education and training. And so the following day, having a specific abstract session on abstracts related purely to the empirical study of medical education and training in neurosurgery. I'm excited to see how these go. Hope that if you guys have interest in this, that you'll join us and give me some feedback about whether you think this is truly valuable, because this is very much an experiment. But I'll say one of the most wonderful things about the CNS is that they support that type of experimentation and innovation and trying new things, which is one of the reasons that I've really loved working for them. And so I'll end just by saying, my path onto the CNS was very fortuitous and probably somewhat random, but has been one of the most impactful aspects of my career so far. Incredible mentors through that organization, particularly Dr. Sharon, who gave me a chance, and Dr. Bambakitis, who's the current president and chose me as his scientific program chair, and has allowed me such incredible flexibility to try new things. So to summarize, I hope that I've convinced you that AI is changing our practice, and also convinced you that recognizing a good idea is perhaps maybe the key to academic success. Building those relationships that are bidirectional with our mentees, incredibly fun, exciting, and important. And that innovation happens both at the individual level and at the organizational level. And in my career, it's been really exciting to be part of both. And that's what I hope I've demonstrated today. So with that, I would say thank you. We welcome any of you to Nashville anytime. If you're ever in the area, please come by and visit. We'd love to continue to strengthen this relationship that we have between Vanderbilt and Sinai. And again, thank you so much for this incredible opportunity. Love to take any questions that you have.
The worst part about these meetings is you can't hear the standing ovation that you would probably get if you were with us, Lola, because that was really one of the best Malice lectures we've ever had. You resonated with me personally and with so many of the things that we speak about here. And there's 100 questions that we could ask. Maybe I'll kick off by commenting on something that you said right near the end. One of the ways we've tried to organize such a big department trying to deliver neurosurgery care across a huge urban environment is the concept of disease-focused subspecialization and centers of excellence, where we project time-dependent treatments out where they're needed and focus resource-intensive treatments where the resources are limited. And that has worked to drive innovation in individual disease states and so on. But there's always a balance between that, which clearly works, and what you're also observing, that treatment-based or research-based or methodology-based organization stretches across multiple disciplines, and you can advance the field in both ways. Really fascinating observation that you made, and you're organizing the whole meeting around that.
Yeah, I think, it's something that didn't occur to me for some time, but I think we're just becoming increasingly subspecialized within neurosurgery. And we know that there's benefit to that to our patients. Right? When we, if I do 100 pituitary surgeries a year, I'm a better pituitary surgeon than I would be if I did 20. But it has impacts on training in particular. And it also has impacts on our ability to collaborate, with people who are doing interesting work in other spaces that we are maybe completely unaware of. And if I go to the CNS meeting and I sit through all the tumor sessions, I'm probably missing some incredible advances that are happening in CV that are actually related to what I do, because I'm focused on the clinical diseases that I treat. And so balancing that is the real challenge. And as a program director, part of my job is to make sure that our residents are great generalists in addition to being subspecialists. And that's a big challenge.
So many people need to ask questions. Trevor had his hand up first.
Hi, Dr. Chambliss. Thank you so much. That was a wonderful talk. I really enjoyed it. My question is just about reproducibility in research. So obviously in science in general, reproducibility has always been a big issue. How has programming and the changing scope of your lab allowed you to help implement reproducible research practices? And I was wondering if you could speak about that.
Absolutely. I mean, certainly the early work I was doing in this space is really flawed in that way. And as we were beginning to do this type of project, we were doing single institution work. Even then, I think we were certainly understood the importance of external validation. And even in some of our earliest projects, for example, where we're using national databases, we would externally validate against other databases. But what you really need is to have great collaborators at institutions that are pretty different than yours. And I like that the chest X-ray story of Eric's, because he chose a collaborator that had extensive resources, but also very different patient population. And even then, we're still talking about American academic centers, right? And that's a real flaw. I think that the technology has caught up to the point where with systems like federated learning, we can get around some of those challenges, because if you can avoid issues of patient security and you can avoid massive data transfers, you can create a much more flexible validation model. And I think that's now needs to be, ultimately, once we demonstrated that works, needs to be taken outside of the academic American medical centers and be demonstrated to have value, pulling data out of completely different settings, many of which may be resource limited, where some of this work may be the most valuable.
Alex?
Thank you.
Hi, Dr. Chambliss. Thank you so much for the amazing lecture. Mine is more of a theoretical question. As all these technologies emerge, I feel like synergism is a big topic. Obviously, with Simulated Raman, with the work of Daniel Oranger and Todd Holland and Dr. Hodgman-Ice and others, in addition to now the new work on liquid biopsies, what do you think is the theoretical best workflow, say, in the next 5 to 10 years, of how we're working up these tumors, both from a pre-op standpoint, intra-op standpoint, maybe minimizing the need for neuropathologists, at least in real time from an intra-op standpoint? I'm just curious to hear your take, since you've been so invested in this research, of kind of the workflow that you foresee being as we emerge from training and going into our early professional careers.
Yeah, great question. I mean, I think what all of us want to do is minimize unnecessary intervention, right? So part of it is looking at that and saying, from a pre-op standpoint, what type of diagnoses can we make, and how comfortable can we be that those diagnoses are accurate to potentially start therapy in some cases without necessarily needing a neurosurgical intervention. So that's the idea of trying to eliminate biopsies from our world for the most part. We're a long way from doing that, but I think that it should be a goal, and that's not going to mean that we don't have plenty of surgery to do. From a workflow standpoint, beyond that, I really think that the question is, can we get people to truly believe in the validity of this type of computer vision pathologic diagnoses? Because people have to be really comfortable making that leap, and I think that that's going to be difficult. I think it's going to take people seeing that for themselves in their operating room, seeing diagnoses made, having a neuropathologist confirm those diagnoses, and watching that system happen over and over again. And I think we're not going to get rid of the neuropathologists. They still have incredible value. It's just, how do we optimize our decision-making in the operating room around in ways that they have struggled to provide value, right? And so it's very clear doing frozen sections they're very difficult to interpret. There's a reason that those answers are not often all that useful. So can we focus on that particular space to try to improve what's happening there as opposed to what's happening on the back end issue? But I do think that workflow ultimately looks like having better analysis coming from our radiologist, using this type of deep learning algorithm to say, here's your differential, maybe here's your percentage likelihood that it is this disease or that disease, allowing us to then make some treatment decisions surrounding that. Intraop pathologic evaluation that is much more accurate than current frozen. And then downstream, using this type of work to really streamline the way patients are treated and get them underway with the next phase of their therapy as soon as possible.
Thank you so much.
We have 9 o'clock. We've reached 9 o'clock. We could go for a long time. You're going to be spending time with the residents. So Jorge and others will let you interact directly. Kostas, did you want to have a comment, say something?
Yeah, can you hear me okay?
Yes.
Lola, awesome talk. I've been following your career and you've done such a nice job, and your leadership in the CNS is quite evident, and congratulations for all you've done. I think it's an exciting time, right? We're like kids in a candy store with technologies, and I love that. That's my passion, and I hear it in your tone and your presentation. It sounds like it is yours too. One of the things that we're trying to do is work on complementary technologies. So the stimulated Raman spectroscopy stuff that Todd and Dan are leading is awesome, and that's here to stay. And I don't think that's going anywhere. What we're trying to do is try to complement that with a handheld device in real time. And we're going to have a plenary talk at the AANS that we're giving on this in a month or so. But the concept is, how do we believe what we see, right? How are we confident that what the tool is using through data management and AI algorithms is really what it's showing? And this device is going to tell you whether it's a meningioma, whether it's a glioma, whether it's a MET. And then the other thing that we're trying to do is trying to figure out what gradation of tumor cells we're in for the infiltrative gliomas. And I just wanted to get your thoughts on, do you think we're heading towards a path of giving probabilities to patients in terms of, probabilities of diagnosis, probabilities of extent of resection? I mean, that's the kind of stuff that I think we're heading to in terms of a more quantitative approach than a qualitative approach that we've been doing.
I totally agree. And I'm excited to hear that talk. I totally agree. And I think that that's going to be a particular challenge, because the reality is, I don't know your experience, but in my patient population, my patients struggle to understand probability. And I don't think some of that is educational perhaps, but also it's someone who's faced with a really complicated, dangerous, frightening disease. And we're asking them to hold a great deal of uncertainty in their minds. And I'll always talk to my glioma patients about that being the biggest challenge of wrapping your mind around this, is that uncertainty. And so I think as scientists and as people who are removed to some degree emotionally from the clinical problem, probability is very useful to us. But communicating that to patients is going to be a real challenge. And telling someone, look, we think there's a 95% probable, chance this is a lymphoma, so we're going to treat you empirically without a biopsy. That's going to be difficult because we're going to, even though that's probably the right thing to do, especially in a tumor that if it is a GBM is unresectable, it's probably the right thing to do. It's going to be hard for patients to wrap their minds around the fact that we might be wrong, and we're going to know we're wrong. We're going to be wrong in some of those scenarios. So I think it's going to create additional challenges in prognosticating. And as I said, we're already bad at prognosticating. I think it's going to take a lot of internal, a lot of focus on the way that we counsel patients, and also work with our colleagues, who are often the ones doing a lot of that counseling as well, neuro-oncology, et cetera. These are not diseases in patients that we treat alone.
Speaking about prognostication, have you tried plugging in gender concordance with your length of stay algorithm?
So
patient?
Turned out to not be, it's not a significant component of the predictive, it's not a significantly predictive variable. So we don't have that. And that point of care model, we built that based on putting in, 50 to 100 different variables. And then we ultimately just shorten it down to those that are the most important so that it's not arduous for the clinician at the bedside. But gender, interestingly, has not played out to be particularly predictive of length of stay or discharge disposition, although I would have bet that it was going to be upfront. Marital status, I also thought was going to be useful, and it turns out to be less useful.
I was thinking about the gender concordance, which has recently been shown to have an increased complication rate for male surgeons and female patients versus.
I'm sorry, I misunderstood what you're saying. Yeah, we have not looked at that. That would be interesting. We don't have a lot of female surgeons, so maybe we may need to really pool data from a lot of different sources to look at that.
Good. Well, there are dozens of questions. This was really exciting. The residents are fortunate to get to have some time with you now. So thank you so much for this. And,
thank you.
And Raj and the committee for selecting the best Malice lecture ever.
Thank you. That's very kind, and I really appreciate it.
All right.
Thanks, Lola.